Good evening, sir. Good evening, all the aspirants present here. Shall we start, sir?
Yeah, sure, I'm ready. Let's start. Hope you can see my screen and hear me well.
Yes, sir. Just a minute.
Okay,
So, good
great.
evening, all the candidate present here. The topic for today is cardiovascular. It is a CBS session, and the faculty that we have here is Dr. Arun Rajasa. He is a senior clinical fellow critical care at Guy's and St. Thomas Hospital, UK. Thank you, sir. So, you can start the session. And to all the candidates present here, it is going to be an interactive session. So, you can also unmute your mics or else drop your text in the chat box. Thank you, sir. You can start.
Thank you so much for the intro. I think some of you were there in the last class, so you already know me. And congratulations and a happy new year for everyone. Hope your new year, you have lots to achieve and your dreams come true. And you are in really safe hands with Farz Academy. This is one of the best courses for EDIC exam, especially for EDIC Part 2. There are nowhere like no other courses which are even close to this in terms of simulation and which is cost effective. So you are all done well to join the FOSS Academy. So let's get oriented ourselves to the CBS session today. I don't know if you have any idea about this exam, but this is more like if you have attended any quiz competition, the rapid fire round, which comes in the end, like you have 10 questions to answer in like 10 minutes or so, and you have like three sessions. So sessions, separate sessions of 10 questions each and 10 minutes each. So overall, the exam is only 30 minutes in a day, but it will be divided in like three sessions, and it's very time sensitive. The questions are long, so you need to read through the exams and be really switched on. You cannot waste time reading the exam and thinking about it. If you don't know, you can just pass to the next question and come back to it if you want. If you have time in the end, you can do that, but don't get stuck. If you're unsure about the answer, just move on to the next question. That's really important. Time management for CBS session is really important, and this is where most of the failures occur, uh, because CCS session we all are like can manage somehow, like we will get most of the points, but CBS session questions are like hit and miss. If you know, you know, otherwise you don't know. So, and it's there is no fixed like pass mark for these exams, so you are compared to your colleagues. Whoever is sitting the exams with you, you are compared to them. So all of them answer and you missed out on that question, so you lose out on a mark and you are at risk of failing even the exam. So you should aim not to miss out on easy questions and try to achieve full marks on difficult questions as well. Okay, let's dive into the session. We all know the basic rules. Let's keep it interactive and try and answer. Treat it like an actual exam and or a quiz competition and go for it. Whoever knows the answer can go for it. Okay. So this is our first question. Interpret the PA catheter waveform. So following it. So this is not a PA catheter as such, but you are injecting a cold saline and you are checking the cardiac output monitor on the monitor. So once you have injected the cold saline, you are getting a trace like this. The top one is a normal one, and this is for you to interpret the bottom one. So who wants to go first? What is your comment on the curve and cardiac output?
Uh, Good evening, sir.
Good evening.
This is one thing which I can see is the area under curve is increased. So which shows basically the cardiac output. So cardiac
Yeah.
output is increased.
All right. Any other answers?
Actually, sir, I think it is taking a longer duration to reach the thing. So probably it is take opposite direction. So cardiac output is different, I guess.
Yes, I'm afraid Manoj is correct and Imran. I gave the same answer as you in the exam. This is actually an exam question for me when I sat the exam, but the answer is opposite. Like the longer the curve and taller the curve, it means it is taking time to reach a peak and come down. So it's suggestive of a low cardiac output. So I can show you the other possible variations of this curve. And if you see, so this is a normal curve. You make an injection of cold saline. So the temperature changes is measured in the thermistor tip in the end of the PA catheter. And you can see it comes down slowly. And if it's taking longer like this, it's suggestive of low cardiac output. And if it's high cardiac output, it's a tall and short curve. So it falls quickly and like even the temperature difference changes very quickly. So it's a small curve. The area under the curve is small if it's a normal or high cardiac output. Yeah. And the other forms can be asked in the question. So this is like injectate being delivered very slow and intermittent injection. It should be a smooth and injection of 5 to 10 mLs over 3 to 3 seconds at least. So if it's longer duration or like intermittent, you get abnormal waveforms and you should discard them. Ideally, you should take 3 measurements taken in the end of expiration and average them. So that's how we make sure it is accurate, right? So who wants to answer this question? What are the limitations or causes of error with this technique?
Temperature of the cold saline
Very good.
and the duration of injection. If you push rapidly, again, there is error.
Yeah. So the method of doing it, you could be wrong with the temperature, could be wrong with the rate of injection. Yeah. Anything else?
And the catheter can be dislodged, so it sometimes can.
Nice. Yeah. Catheter malpositioning, catheter related problems. What else? Where you cannot rely on the cardiac output from this measure.
There is an RV failure, anything?
Any intracardiac shunt?
Very good. Excellent question. Excellent. Yeah. Similar in those terms, tricuspid regurgitation as well. So it's going to cause errors with the cardiac output monitoring. So catheter malposition, the patient breathing pattern is very erratic, intracardiac shunt like ASD, VSD or PDA, so causing volume overload and errors in the dilution technique. And tricuspid regurg, arrhythmias as with other cardiac output monitoring, and injection techniques like slow delivery or rapid or the cold saline not cold enough. So these are the other causes of like errors with this technique. You happy with this? So your exam questions can be from curves, any curves in the ICU. You cannot even imagine all the curves they are asking. So it can be any curves, and it's difficult to find a single source where you can read about all the curves. So you need to do your research and find out about all the curves and learn about it. There is not I cannot recommend a single source which gives all the curves in one place. So it can be any graph, any curve, any clinical scenario, biochemistry, radiology. So it's really interesting questions. Fine. So the next question. 65-year-old woman with STEMI post PCI deteriorates with pulmonary edema. A pulmonary artery catheter is placed for guidance. Interpret the PA pressure tracings. This is your PA trace. Based on that and the clinical scenario, what is your diagnosis? So what the PA catheter is, trace is showing?
Fusion of A wave and C wave with mitral regurg.
Mitral regurg, absolutely correct, but it's a fusion of C and V waves or a tall V wave, not the A and V wave. So it's similar to a CVP trace in terms of assessing for if it's in a CVP trace and has a similar pattern, you would have called it tricuspid regurgitation with a C wave which is being more prominent. So they have labeled it, this is the prominent V wave, and it's occurring in systole, right? So that correlates with acute severe mitral regurgitation. So, what is the cause of mitral regurgitation? What are the mechanisms of this regurgitation in this patient?
MI can be the cause for mitral regurgitation.
How?
Papillary muscle necrosis.
Yes. Papillary muscle rupture is one
Rupture.
etiology. And any possible other mechanisms?
The other possible mechanism is because of MI. If the LV starts failing and the volume of LV goes up, then the annular dilatation is one of the causes.
Exactly. That was precise answer. That's what I wanted. So that we call as functional MR due to annular dilatation. And we are worried about papillary muscle rupture as well. And which papillary muscle is more common and why? There are two papillary muscles, right?
Posterior.
Posteromedial.
Posterior.
Can you tell why, Manoj?
Because PDA will be the usual culprit artery as a dominant.
The reason is the anterolateral papillary muscle can get dual blood supply.
Dual blood supply, yeah.
But the posteromedial, as you said, is predominantly from one blood supply. So if that goes off, there is high risk of papillary muscle rupture, and that usually causes torrential MR, and the patient decompensates, which needs immediate management. So how are we going to manage?
Surgical, immediate surgical management.
That is one option. What will you do in terms of surgery?
So we have to either repair the mitral valve or replace and do first we have to do angiography. We have to see what is the vessel blockage.
Yeah.
If there is a vessel blockage, we have to first do PTCA. For that, we have to put a stent. Then we have to take the patient to the OT and have to surgically repair that.
Yeah.
Bypass.
Yeah, so in this scenario, patient already had his PCI done, but it's a late complication of MI, he developed a pap muscle rupture. So based on what type of mechanism it is, if it's functional, mostly we try to manage it like supportive measures, medical management. And if it's severe still, we can consider surgical options or interventional options. So if it's pap muscle rupture, patient is going to be unstable most of the time, so they will need some support like mechanical support devices to facilitate any procedure. So they either can go for MVR or TEER. TEER is transcatheter edge-to-edge repair, which is like a catheter-based intervention which can be done in cath lab. They just oppose the two ends of the leaking mitral valve, so it downgrades the severity from severe, if it's torrential, or severe to like mild to moderate. So that is enough for the patient to manage or cope with the regurgitation. Then later on, a definitive surgery or procedure, if required, can be planned. So that's how we manage post-MI MR. So third question, it's 72-year-old man is on an IABP for cardiogenic shock following a MI. You are called because the patient's hemodynamics have deteriorated, maps have dropped, and the IOBP console is alarming insufficient augmentation. So the screen displays the following balloon waveform and arterial waveform. So what are the possible differentials here?
Discharge
Early
the
inflation.
position.
What was that, Manoj?
Position malformation.
Position abnormality, reasonable, yeah.
Early inflation looks like.
We will look into that. Could be, yeah. Anything else?
Early deflation. Early deflation.
All right. Any other guesses?
Sense of augmentation is very diastolic augmentation is less.
And what about systolic augmentation?
Hmm?
Right. Let me show you the normal IBP waveform, then we will come back to it. Okay. So this is going to be your normal waveform. So this is an unaugmented normal patient's rhythm, and this is a augmented waveform, right? So here is the dichrotic notch. Just around the just before the dichrotic notch, the balloon inflates. So the systolic pressure is augmented, right? I mean, in the diastole, this is the diastolic augmentation. As Dr. Mohammed said, the diastolic augmentation was not there, right? And this is the assisted systole, and this is the assisted diastolic pressure. So this is how it normally looks, and early inflation and deflation looks like this. So early inflation, it is way higher before the aortic valve actually opens. So this is early inflation, and late inflation, it's after the dichrotic notch. So this is definitely late inflation. So you just need to adjust the timings. Early deflation, you can see nicely here. So the balloon is deflated and still the cycle is still going on. And late deflation, it encroaches onto the next cycle. So most worrisome scenarios are late deflation and early inflation. So early inflation kind of prevents aortic valve from opening, and late deflation causes increasing overload onto the next systole. So these are like worst scenarios. These two are like just ineffective augmentation. Early inflation and late deflation can cause harm basically. And this is the arterial waveform part of it. And we don't often look at the balloon waveform. It's at the bottom of the screen if you look at the console. And usually there is a filling pressure, which is around 10 to 15. And early systole, like overshoot when the balloon inflates, then it reaches a plateau, then deflate, there's an overshoot, and it comes back to the baseline. So now what do you think? So two things are happening here. One, there is no, the diastolic augmentation is very poor. It's less than the actual patient's systole. And this is not coming back to baseline. It's like tailing off the balloon pressure. So there are differential for each of them. So let me give that to you. So if the patient's preload is very low or the patient's cardiac output is very low, it can have this picture. In spite or despite the balloon pump working normally, the cardiac output is too low for it to augment, right? So that can cause this impression. Here the timing seems appropriate. If you compare the dichrotic notch, it's just in front of the dichrotic notch, so it's not early inflation. Other possible reason, the balloon is too small, so it's not augmenting enough, or the position could be too high or too low, so it's not working well. And with respect to this, the possible reasons are there is a leak in the balloon, so that's why it's not coming back to baseline. So you need to check the line for any leak or check the cylinder if there is adequate helium pressure. So helium is the gas we use for this, right? The orange cylinder. And other possible, if it happens all of a sudden and it's not working, then we should think about balloon rupture. So these are all possible scenarios or questions with IABP. There is nothing more they can ask about this. So if you understood this much, that's more than enough. So how would you manage a balloon rupture if it happens?
Replace it.
Replace, yes. Immediately, what you do? Does it cause embolism or cause any hemodynamic compromise? So what is the gas I said we are using for IABP balloon?
Helium.
Helium. So helium is soluble, but it does take like few minutes to like dissolve in the blood. So it can cause embolism. So immediately we do ask like for air embolism patient management, just put the head down, avoid like stroke from this, and then we can troubleshoot the IABP. And other things are like if the patient RS, we do like regular ALS and chest compressions and supportive management. But as you said, we should replace the pump as soon as possible and disconnect the balloon from the console if it's still attached and taking some time to replace so that it doesn't just pump air into the patients. Yeah. Any doubts with this? Hope you are all with me. If you have any doubt at any point, please stop and we can resolve that.
Yeah, okay, sir.
All right. So moving on to Impella, 65-year-old man with refractory cardiogenic shock post MI is being supported with a Impella CP via femoral access. He has been stable, but you are called for a new hypotension and multiple alarms going on the Impella console. So the map is low. So the Impella console is showing this waveform, right? And the free hemoglobin you have sent is 4 grams per liter. So how to troubleshoot? So what is the waveform showing? Have you? I don't know if any one of you have worked with Impala. I don't expect you to understand, but just have a try.
I have seen one case, sir, with Impella. So this looks like there is very decrease in the Impella flow as per the thing. And hemoglobin has been dropped.
So that's free hemoglobin.
Okay.
I think I will start with explaining you. Then we can come back to this.